great, we're live.
So I think we should start. And I'm going to call the meeting to order, and I'm going to start with an apology. I am so sorry I am not there in person. You all know that I am the one that's obsessed about being in person. I think it's incredibly important. I think that having a hybrid call is the most awful, difficult thing to do. And I hate being the chair, but I have a really good excuse. I am in Chicago. My youngest daughter just had her first baby. I was on the first flight out to Chicago yesterday, 2 days ago, and taking care of a lovely couple who don't know what hit them. She came quite, but they're learning fast, so it will all be good. So I am going to thank you for bearing with me. And again, I am sorry. I would be introducing Dana as a new member, who I think is also soon to have a baby. So I was going to be thinking, oh, this is appropriate. She'll understand anyway. And warn her that they can come early. But we'll leave that to the end. And Emma, thank you for taking Alex's role in this. I know you will do a good job, processing all of the technology for us. So calling the meeting to order, do I hear a motion to review the minutes?
So moved.
Second?
Second.
Great. I believe you all had them. Is there any discussion on them? Hearing
I
none.
wonder if we could receive draft minutes a week or two following the meeting when we might actually remember what we said.
That's
Oh.
fair. I think you can accommodate that.
Yes.
Organizations tend to do it at one extreme or the other.
Yeah.
Yeah, I'm always, got it. And then I have to be reminded what we all said sometimes too. So it's a good combination. Any other discussion on the minutes? Great. I'm going to have to do a roll call. Since I don't see you, you're going to have to answer yes, no. And I will just go through the list of people I think are there. Okay, David.
Aye.
Karen.
Hello.
Sandy.
Yes.
Jean.
Yes.
Niels.
Yes.
Alan.
Yes.
Is Adriana there?
Yes.
Great. Didn't see you. And Brent. No, he's not there. Okay. So hearing none, minutes have been approved. Thank you very much. We have a wonderful agenda today, a full agenda. We're going to begin with a discussion of the Advanced Provider Interactive Dashboard, and included in that is a discussion of a report that is actually not part of the strategic reporting requirement, but has been one that people have been thinking about and asking about for some time. So this will be an interesting discussion too. Then we're going to review our priority areas. For those of you who remember, they are the items in the strategic plan that we as a council said we wanted to have updates on, and also input into next steps. And then, and Liz is going to do the discussion of the interactive dashboard. And Erin and Haley, I believe, are going to be doing the priority areas. So I'm going to be turning it over to them during this conversation. And then Lauren, you're on again for a number of items. You're going to begin with the budget and legislative updates. And if you recall, all of us are always interested in particular to anything that involves CHIA and might include responsibilities for our organization. And then Alan, you requested a question to be discussed at the council, and that is referring to the steward situation. Lauren has provided the council with the information she has been providing so that all of us have some context and some understanding of some of the data that is our responsibility to provide to those that are involved in this. And then we're going to talk about the ABCD briefly. I always feel badly about this, Lauren and team, because this is where much of the CHIA staff spends its time. It's incredibly important for those of us that have been through major system conversions or changes. It's always a really heavy lift. So keeping updated on that and understanding where we are is important. And then if there's time, a review of the current and upcoming publications as always. So we have an interesting couple of hours ahead of us. I'm going to turn it over to you, Liz. I believe this is the first time you've presented to the council.
I'll make my way up before I.
Is this their first?
I may have done once remotely during
you're right.
the depths of the pandemic.
During the pandemic, how can I forget? Yes, absolutely. So anyway, welcome. Thank you.
Thank you. Awesome. All right. So this is sort of a two-parter, as you'll see. So we'll kick off with more of the hospital side and the work that has been done there. So on that note, last year, CHIA, HPC, EOHHS all worked together on a joint effort to really improve CHIA's financial monitoring of the hospitals. And on that note, we worked as a group, we consulted with a variety of experts and ultimately worked towards this goal, which is to enhance more of the health system level data in our current analysis, as well as really establishing a standard set of financial metrics that we'd be using moving forward for both our analysis as well as our reporting. And that is something that we use for the ongoing monitoring that is statutorily required for both the hospitals and their health systems, as well as any identification of those entities that we see having financial concerns. So getting into the next slide, this sort of just breaks down a little bit of a summary of what happened through that process and the goal of that. So essentially, we've shifted our focus from being more strictly hospital level to really tying in the system level data and providing more of a look at that higher level focus. We've also went from being more profitability focused, really just those sort of losses, revenues, to a more robust, well-rounded, some days we can talk, look at financials, which includes profitability, liquidity, solvency, and really the change in net assets or their worth at each of these entities. We're also looking to do more frequent refreshes of the data to really include the most recent data possible rather than waiting to do the refresh at the end of the year when all of the data is available. We're trying to get that up there as soon as we feel comfortable. And then most importantly, we feel as though we went from a place that was a little bit disjointed. There's a lot of data in a lot of places to really creating what we've called sort of our one centralized, our performance dashboard that includes both financial data, it includes some utilization data. And again, it is linked together, the systems and the hospitals in one place. And of course, by the way, please interrupt at any time if there's any clarifications or questions that I can answer.
Alan,
Are the data on the separate physician corporations also included?
The affiliated physician organizations, yes, is included in there as well. Yes.
Thank you.
Thank you for that call out.
So how frequently will the data be updated now? Does this mean we won't have to wait for the quarterly financial performance updates?
So there will still be the quarterly financial performance updates. The goal, most importantly, has been that the annual data tends to be the most sort of robust set of data that we have. And in the past, we had to wait for each of the hospital's different fiscal years to end to really get a full data set out there. So the aim is to get it out there, even if perhaps every single system is not available at that time, we could still publish those that have closed and have ended. And same note is sort of, we have different hospital cost reports as well as financial statements that come out at different times. So rather than waiting for the entire data set to be available, we could get financial statement data out earlier than the cost report data.
Thank you.
So
That makes sense. Thanks.
same timing of data, unfortunately, but coming out much sooner, hopefully. So with that, we thought we would actually open up the dashboard, which I think, as a visual learner, I think is always the best way to do things. With that, we thought we would actually open up the dashboard, I think, as a visual learner, I think is always the best way to try. Are you all able to see the screen that I'm sharing?
yes, thank you. It's great.
Great. Okay. So this is, as we mentioned, sort of our centralized dashboard. This includes both this system. Yes, thank you. Right. Sorry. We're having a little feedback over here. As we mentioned, sort of our centralized dashboard is think we're back in action. So again, as I mentioned, this is sort of our centralized dashboard. This includes a variety of clickable buttons that you can get into more detail on each of these. I was gonna sort of highlight two, and then I would love to sort of open it if there's any specific data that you might be interested in, anything that you can see here that you'd like to look at in more detail. But in one note, so what we have at the top, which we call our compare system by financial metrics, this is the, it will be the most recent year of data. So as I mentioned, it's hospital fiscal year 2023. It includes all of the systems we have in. As mentioned, some of the data that's not in yet is blank for the time being until we can fill that in. But it includes each of the hospital systems in the state, and then the metrics that, again, we had mentioned that we include the profitability type metrics, liquidity, solvency, and then through this, we can actually filter the data so you can see how they stack up against each other during the most recent year for each of the metrics that are included. So soon this will include all of the data as well. And then on a similar note, looking to how we tie to the systems to their affiliated entities, both their hospitals and their affiliated physician organizations. This includes a 5-year trend of the most recent data along the same metrics. So just going alphabetically, we'll start with Bay State. It includes their last 5 years of data, and then you can select any of their hospitals or affiliated physician organizations here to also see how that compares to their affiliated entities. I know it's a little small for some of us in the room, including myself, but hopefully everyone will get the chance to look through this in more detail. And on that note, I'm happy to sort of go back to the beginning, or if there's anything that anyone would be interested in looking at.
This is available on the website live right now.
Yes. And we try as much as possible to know which the data time periods is, just so to make it as easy as possible.
How is the data affected by either delays of received data from one particular hospital system? If, for example, something is incomplete, is it still uploaded for whatever you do have, or how does that work?
That is exactly the goal. And what we would do is essentially add, and you'll see for those hospitals that had calendar year end, we're still completing the review of that data. So everyone else is available, and there's sort of a note that they are going to be up, hopefully shortly, coming this summer. And same would be if there was incomplete data questions that are still out there that we'd like to complete, we would still provide everything else that we have in that data set with sort of a caveat note to those that we are still completing.
Liz, it's my sense that on the financial metrics and some of these key metrics that help us understand the performance of these big health systems, that a lot of those metrics that you're showing here were things that were on the website before. But here, you're really able to see them all in one place. Whereas before, you might have had to click through a couple of different reports or look at different data books to kind of see that. Are there any net new financial metrics that we should know about that are being displayed here for the first time?
So as part of, that's a great question, because to your point, what we did hope is that hopefully it's easier to find than sending people in a few different directions. So we did bring back in, we have current days cash on hand, which was not previously being used. And then there is the long-term debt to total capitalization was also a newer metric that came out of the discussions that we all had as a group. So there are sort of two new metrics, some that were already included in data books, and then some that is really just, to your point, really displaying them in hopefully a more cohesive way for everyone to be able to access all at once.
Liz, I have a question. This is Jean. The data is really helpful and convenient. Is there a process by which an agency or some sort of systematically identify, interpret, and act upon the red flags versus just, we let the transparency itself do the work.
And I think, I mean, I will say, at least from, I think, the state agency's perspective, I think we've been trying to look at it from that perspective of, is there someone we're seeing declining over years, in particular, when we look more at sort of the 5-year trends, perhaps? Is there anyone that is perhaps an outlier compared to the other systems that we're looking at? I think those are some of the most important things we're trying to catch as we look towards the future. And that's something we're doing on an ongoing basis, sort of in collaboration with our other state partners as well, to make sure that that data is both available to everyone that may be interested, but that we are catching and looking towards, and really we can follow up with those systems and things like that to ask more specific questions on their data.
Thank you. I
Gina,
think that would be helpful. Yeah, just then, someone needs to reach out to the system to have a organized dialogue to get the next level of information to make sure that we don't lose signs. I think that process, the clearer, the better. Sorry, I think I interrupted someone.
Sorry,
Yeah.
Gene. I was just gonna say, from the Health Policy Commission standpoint, we use this financial information across a range of different activities. You might imagine when we're looking at material change notices, when organizations are proposing new mergers or business organ changes, we're examining their financial performance. These are some of the very financial metrics that we'd be looking at. We would be absolutely in a dialogue with these provider organizations on their financial performance, going that level deeper with them to say, in certain circumstances, they may be proposing a transaction motivated in part to try to help stabilize their financial performance. And so we would be using this type of information to then go that level deeper when we're looking at changes, not just on a specific transaction, but looking at changes across the marketplace, looking at changes in the pediatric market or changes in the maternity market. We'll look at things like what we see in changes in financial performance by these health systems correlate with financial performance. So I think we are using this across a range of different analyses. And I would say we know that the Department of Public Health and EUHHS are similarly using this across a range. So I think that was part of the motivation for this kind of joint effort to have this kind of more standardized set of these specific metrics, and then to have this be transparent to the public as well. And so that what we're displaying out to the public are in some ways the very same things that we're internally analyzing and looking at. And, internally, we're doing that further step of like looking at benchmarks, doing red flags, looking over time. But certainly, this, I think, is a level of transparency to the public, which I think is an asset.
Great. Thank you. Thank you so much, David.
If an individual hospital, say, were identified as going downhill financially, since no one is actually accountable for identifying and stabilizing which hospitals are needed to protect the health of the public, because payers are separate and true in every state, would it be useful to prepare a list of the hospitals that are in trouble now or have been deteriorating so they might be in trouble in the future? Now, there's a downside to that, of course, which is that vendors may ask for a certified check at the loading dock before they. On the other hand, it might make the problem more visible to doctors, patients, others, and perhaps a committee of payers involving Medicaid and commercial insurers might be convened to see what they could do. But I wonder whether that would be a step for us to take, since you all have the data, or for others.
I think that the current process does contemplate the role for CHIA in identifying systems that are experiencing their financial challenges more so than others. It's all sort of on a relative basis. And absent sort of one definition of this is what it means for a hospital or health system to be in financial trouble, we've put together a suite of metrics that we feel like are most informative and indicative of the financial health of a hospital or their health system. And so we do believe that it is CHIA's role to organize and report the data in such a way that allows others to, and the public, as David mentioned, to be able to see them sort of side by side to draw those, whatever conclusions, whether it's public or one of our sister agencies, conclusions that may be necessary to, that may sort of necessitate action one way or the other. And so I think for CHIA, what we've been trying to iterate and improve upon is how do we analyze and report the most sort of salient, relevant, useful information in a way that allows for that comparison without having to rank them like number one through number whatever. So that we can whatever, say, agency or the public's sort of most important metric is, allows them to filter and look at the health systems juxtaposed against each other to say, here's the biggest concern on with respect to days cash on hand. Another entity may say the debt ratio is the most important metric. So I think our goal here was really to lay out in a comparative and useful format with a standardized set of metrics.
I think this is a big step forward. At the same time, for decades, analyses have been done of predictors of hospital financial distress and bankruptcy. There are multivariate analyses that were taken into account measures here, also measures like payer mix and neighborhood demographics and other things. It's a particular interest of mine since the 1970s, because I was traumatized by the relocation of the Brooklyn Dodgers. It turns out that Major League Baseball teams leave the same neighborhoods that hospitals leave. So,
Are you serious? I mean, they really do leave?
yeah,
So Fenway goes.
I'd be happy to make my paper available from Cooperstown. But even more seriously than involving baseball. Having available a variety of metrics is, I think, a valuable foundation, but systematizing them into a predictive model that's been tested over decades might be very helpful in guiding state policymakers to the extent that they're willing and able to become involved in intervening more quickly and more effectively and less expensively.
Yeah. I would just add, Dr. Sager, at the Health Policy Commission, we've made policy recommendations to the legislature to do that and to revitalize that type of proactive financial planning and health planning. And I know that is, part of the active conversation that's in Beacon Hill these days. So I think the point you raised, though, I think is one that is a careful one, because if the state labels a hospital as being, distressed, you don't want that to become a self-fulfilling prophecy, right? So how do you carefully do that in a way where the state may be able to proactively help, if that's the case? I remember when Chapter 224 was first passed, there was a trust fund that was called the Distressed Hospital Trust Fund. And the HPC was in charge of distributing funds from that. And I can tell you the first thing the hospitals told us was like, please don't call it this Distressed Hospital Trust Fund. We don't want to be called distressed hospitals. So we called it something else. So I think these are part of active conversations with the legislature right now.
It's, as I said, you don't want people demanding a certified check at the loading dock. But, and I think it would be important for everyone involved to be careful. But having more accurate measures out that were prepared over many hospitals over a long time could result in more accurate information rather than information that someone might grab and be frightened by and highlight that, when it really in context wasn't that important. So I think it's a
Um,
911 is down.
sorry, it's a public safety message, but
We're all gonna get it.
All right.
it's hot.
Yeah.
It's interesting. But I think, I wonder whether it's easy for me to spend other people's time. But I wonder whether it would be worthwhile to inventory, short-term, like William Cleverly and other predictive models of financial distress and closing, and more medium-term, like 5 years ahead, to get a sense of what's out there, what could be done, and whether with a minimum of effort, with data already available, it might be possible to come up with more accurate information that could be shared among interested payers, for example, as well as, of course, with and through the Health Policy Commission.
So we can certainly take that back and it is sort of timely and relevant to one of the last agenda items, which is an update on the pending health legislation. And one of the provisions is to establish the Health Planning Council at HPC, and as CHIA's role in provisioning data analytics, I think that the ask here, which is do an inventory of existing models out there that could help with that predictive exercise. We can certainly take that back and working with our colleagues at the HPC, perhaps get a sort of jump start on whatever health planning work comes David's way.
Thank you.
And I think just also to wrap that up, and one of the points you did make, I did want to mention that part of this, we did also bring payer mix and things like that, the relative price that the CHIA group here does as well. So all of that is actually right in that 5-year trends as well. So we did have that on the mind. It wasn't as though that wasn't part of my financial spiel, but it is in there. So I did want to make that note that we are, I think, seeing and thinking in a similar vein when we put that group together. So
We knew you were going to.
we think sometimes, So, all right, we'll see if we can shift back to the slides if hopefully but of course, that is up there and available for anyone to click through. And if any questions come up, by all means, you'll know how to find us. All right. So we'll be shifting gears a bit here from the hospital health system world into sort of the long-term care sector and the nursing facility transparency proposal that we have put forth sort of for discussion today. And again, for any questions and clarification that we can have on that. So this is a new initiative that would be proposed. The aim is really similar to what we've done with hospitals to increase the transparency of their performance, as this is something we have not undertaken at CHIA in this time. So right now, CHIA as an agency collects annual nursing facility cost reports. They include a variety of information on costs, revenues. They have some financial statement data in there, but it has primarily been used to support the mass health pricing, the rate analysis. That has been the goal. We are looking to, based on feedback we've heard from stakeholders, that there's interest in conducting a financial analysis on these entities as well to see if we could identify the facilities that may be at risk or have some financial concerns, leveraging off the work that we've just showed you on the hospital and health system side. And one of our goals would be to essentially make this more accessible as well, create a similar type of centralized dashboard that could be used rather than having it be more based on a public records request or just the data that's sort of in a static form at this time. So just to give a sort of very, I think, high level piece, there's a lot of numbers on there. I won't get into all of that, but just a note that we do collect, again, the cost reports from their facilities. There's also cost reports collected from their affiliated management companies, if there is one, as well as an affiliated realty company, if there is one. So this is all the data that is already being collected on an annual basis here at CHIA. And the nursing facility cost reports do include sort of a very similar standardized financial statement data that we collect on the hospital side. So we feel that we could leverage that information. There are approximately 330 nursing facilities that are accepting mass health patients, which means they file a cost report with CHIA. And there's a whole bunch of, statistics, as I mentioned up there, just to give a sense of the scope of these facilities.
And I think, Liz, it's just worth calling out the significant number of nursing facilities that have an affiliated management company or realty company, which we know are often sort of drive a lot of the operations and decision-making within the nursing facility. So I think that's, wanted to call that out because it becomes relevant to the phasing of our analysis that Liz will talk further detail on.
Yes, and in that note, as you can see, I mean, almost 3/4 on each have an affiliated management company or realty company. So it's a significant chunk of that piece. And so it's something that we're thinking about in more detail as we go forward with this.
A couple of researchers, I think at National Bureau of Economic Research, found that a lot of nursing homes that are part of larger entities or have things you're talking about, tunnel their profits out of the nursing home entity and out of the nursing home cost report by showing higher fees and other expenses. Is there any way of capturing that?
And we will absolutely, that is part of this. And I think there's still things we are untangling. That is something I think we're clear on, is that understanding the ownership structures and how there are sometimes related entities that may not own the facility or vice versa. We're still, I think, untangling some of those webs that do exist. But within the cost report itself, there are the management fees that they pay to those companies. So that number is there. We will also, again, be able to see sort of how that changes over time. There is the rent that they pay to the real estate company. So you can again see how that may have changed if it rises, what the rate sort of that is. So that we would say very comfortably, I think we have that data already. Understanding in more detail some of those entities, I think may take a little more time, and that's something we're working on, certainly.
It may be that National Bureau of Economic Research report would have, since they identified the transfer of profits out of the nursing home, there may be, they may have some ideas on ways of capturing that.
I appreciate that.
Yeah, I think that will be a helpful resource that we'll love to connect with you on giving that specific resource, because I do know one thing with nursing facilities is that the structures, most of which are complex with the management companies, they can take different sort of shapes and sizes, and so they create LLCs within LLCs, and we know it is a very, very messy web in some instances, and so we may have to use sort of different strategies based on each individual management company or realty company. But this is something that we are also, in the immediate term, we're working to figure out what we can collect and report through our existing authority. And we're also having conversations with the legislature as they're working on market oversight legislation, so that we're creating a more express authority to be able to compel information, financial statements from not just the nursing facility, but multiple layers of their management company or realty companies, knowing how tangled they are. So sorry, I didn't mean to preempt.
I appreciate it very much.
Next slides.
So again, I think this gets into sort of, this is the initial proposal with the expectation this is something that would continue to grow. That we're taking, I think, what we feel we have now, which would be an initial analysis that would focus more at the facility level. That's the data that we sort of have most readily available, and that we would, again, similar to what we just walked through, have a Tableau-based dashboard that would be available so that you could click through each of the individual facilities. Given that there are 330 plus, rather than, individual pieces, it would be something interactive that would be made available. And there's a list of a variety of proposed metrics that we would like to include with input and interest as well, but there are sort of characteristics, things like where they're located, the beds, all of that information, quality information, payer mix that's available. And then again, it gets into similar financial metrics that we mentioned on the hospital side. So profitability metrics, which would include their revenues, expenses, profit loss, but also those fees paid to the management company, any rent that's paid to a realty company, liquidity metrics. The solvency would only be for that small percentage that owns the building. All of those that have a real estate or realty company related would essentially not have the assets available to do any of these metrics. And then really their net assets or equity, similar to what is done on the hospital side.
Liz, can you say a little bit more about this, relatively light mention of quality? Because, nursing home business historically has been profitable business. That's why you have so much for-profit presence. But profitability itself is not a crime, right? Only when it's at the expense of quality. So how do we ensure that there is sort of staffing ratios that are up to standard? How do we scrutinize their electronic medical record, for example, to validate that they're indeed seeing their patients and then applying the type of care to their patients according to standards? Maybe this is out of scope for this, but I just don't think that you can separate the financials from the real issue, which is whether care is happening.
And I think our goal is certainly to include quality information, not to skate over it. It's that I don't think we have the final quality metrics that we would prepare to include. It could be the CMS metrics. There could be, I believe DPH also has their own metrics, as well as it does have an acronym, but the DCCQ, which is a direct care cost quotient, which notes how much of the revenues are applied to direct care costs. So that would be something that we're proposing to include. But I think there potentially is certainly more. And so I think we wanted to note there will certainly be quality information included, and it would be, again, on an individual basis. What that will be in its finality, I think we are still finalizing, but certainly interested if there's any specifics that we could add.
Yeah.
Such as staffing. I think that's an important point that you make of something that we could look into.
Yeah, I think that just to build on that, as it is a little bit federated in terms of the quality requirements and directives. So DPH has the hours per patient day data. CMS has the 5-star quality score rankings. Mass Health oversees the direct care cost quotient. And so I think the goal here would be to use the data from our sister agencies and CMS to compile and put all in one place. But again, I think as Liz offered, if there are other quality resources, or you feel like it would be more helpful for us to just pick one quality related metric, that's the type of feedback that would be really helpful. We can come back to.
I was gonna say, I think that is included sort of in our final wrap up, so we're happy to definitely make that into a longer conversation. And this is, of course, not a official mock-up. This is just taking some of the pieces of things we already published to give a sense of all the information we'd like to get out there on the facilities with the similar sort of drop-down function that we currently have on Tableau. We would note that it would be sort of at the individual basis. We've had potential discussions of including perhaps a regional indicator, so you could see all of the facilities in that region. Perhaps it could be by those affiliated with a specific management company, and then you'd see those facilities. So there's some various pieces I think that we could roll into the final version, but this would be in essence what we'd hope to do, which would have a whole bunch of characteristics information that you could see at each level, more revenue, expense, profitability metrics, and then the whole gamut of financial metrics that we've mentioned a few times. So in terms of timing on this, we are working now on the analysis of the 2021 and 2022 data, since those data sets are complete at this time. The goal would be to prepare that analysis and roll it out to stakeholders, including the facilities themselves, to ensure that the data, that everyone has seen the data, they understand, as this would be the first time we'd really be calculating these metrics for some of these facilities. And then following that and taking the feedback that we received, we would then apply that analysis to the 2023 data with the goal of publishing by the end of this year with 2021 through 2023 data available. And then moving into sort of that next piece, that piece that, as we've mentioned, we're sort of working on untangling that web, those related entities, hoping to bring them into the analysis for the following fall. So on that note, I know there are, a few questions that we appreciate everyone's feedback in terms of both the approach, the proposal that we've put forth, and then if there's anything, including financial, but also quality characteristics, anything that folks think would be helpful to add to this as we start to think through, whether it be our first iteration, future iterations, et cetera.
I would just echo Jean's point that I think staffing and workforce metrics are going to be really important here for understanding like the context of the financials. And so I don't know if that means that for fall 2024, we just have a better sense of the scope of data elements that are available, and then we can discuss like which are the most relevant and salient. But I think that those will be important to add context to financials.
Just want to echo that. I think the contextualizing the data in this sense is going to be really important because there are so many different factors. And I think in particularly when you were talking about quality metrics, like picking one, but it might be good for us as a council to see all of the different options and then like come together and figure out which ones we think are most representative. Because I think if you start modeling different quality metrics, people will pick and choose from different methodologies, and it's not necessarily something that would lead to an accurate conclusion.
Yeah. I think the September meeting might be a good time for us to, we can put together sort of the menu of metrics specific to quality and bring that for further review and ideally landing on one or two to utilize and layer into this dashboard.
Go ahead, Faye.
No, I was going to ask if there are other questions. David, go ahead.
Supportive of the concepts and approach. I guess Liz, just a kind of a more global question, like 330 entities. That's a lot. It's 9/1. I guess I'm just trying to get a sense of like, maybe you have to kind of get into it and do it the first time to answer this question, but like, what sense do you have of the data quality here? And like, how much work is this going to be? Doing 330 entities, that's a lot. It sounds like, as Lauren, Executive Director Peter said, there are a lot of different flavors and characteristics here. Diving into this project, like how much of an albatross could this end up being, versus your confidence level of like, okay, no, this is a doable project, we can do this. Like,
Yes.
Where are you at?
And I think we feel very confident in the facility, sort of individual facility level data. I think that data has been used most primarily. Realistically, at the end of the day, it's the data that I think has had the most use over time. It is also the data that they have the most access. As Lauren mentioned briefly, those that we have sort of the authority over is the facilities themselves. So that's the data I think that we've looked at and feel that we can confidently put out data that says, of course, we're going to bring it to them, make sure they understand how we calculate these metrics, provide feedback if there's any concerns. But I think it's a pretty standard set of what we're using, what they've already been reporting realistically. It'd be more just making sure there aren't any data quality issues within the data itself that they reported. But I don't think we have certain concerns there. I think probably where the challenges come up are those related entities and understanding those, given that they are not just an individual. They can be sort of understanding how maybe the parent organization there works, who we are actually hoping to understand the data from in order to put something out there. Because I think at the facility level, the data really is theirs. At the management company or realty company level, there can be a variety of realty companies that all report up to the same place, and understanding how that all works, I think, is probably the biggest, I think, obstacle that we're looking at over the next year. But I think the facility level financial analysis, we feel more confident in based on what we've already done and sort of leveraging what already exists out there.
That's great. Thank you.
David, maybe I'll expand on your question. What about the impact on the resources staff of CHIA? This is a new one for us.
That is fair. I think it could involve more staff resources, certainly, given that I think it involves two groups realistically, those that have been collecting the cost reports and use them for the pricing, as well as the group that I work with does primarily hospitals and would be pivoting to doing both, because we of course would not be getting rid of any of the current analysis that we're already doing. So it could potentially be more resources in order just to make sure that someone is paying attention to both at the same time, as we wouldn't be stopping one to create the other.
Thank
I
you.
think I would say the scope and the level of resources needed to sort of tackle this second phase of this, which we're thinking about as the related entities analysis, we'll have better insight into the level of resources and time, and sort of further digging and sort of chasing in terms of cost reports and financial statements from these entities. We'll have a better sense of that, probably early calendar year 25. And I think that's the moment to David's question of that we could say, we could capture maybe 200 facilities based on some of the large management chains, because we know some of them own up to 20 plus facilities. And so if we could capture 80% of the facilities and maybe perhaps the data shows that those larger chains are the more fiscally challenged or challenged from a quality standpoint. And so I think we will have a better sense of scope and whether we need to focus our efforts once we see that initial round of data.
Anything else from council members? Certainly is a need. I think there'll be a number of people that are pleased that this is happening. Thank you. We're going to transition to the next topic. We're pretty much on time.
Thanks,
Great. So this is Erin and Haley. I'm not sure who's going to go first in terms of the priority areas as identified in our strategic plan.
We've got Erin on deck first.
Hi, good afternoon. So I'm here to provide updates on our behavioral health and primary care work. As a quick update on our behavioral health dashboard, we brought this to you last meeting and really appreciate the feedback that was given, had a really robust discussion. So as an update in terms of where we are on that, so the team is continuing to refine metrics and measures based on the feedback of this council. We are currently in the process of finalizing those and evaluating them for data quality as well as data availability. We have taken additional passes looking based on feedback of, are there measures that can get at additional places of service along the continuum of care? And also based on the feedback of this council, we are moving full steam ahead where the dashboard materials will include an interactive Tableau workbook in addition to the static PDF dashboard that will have the look and feel similar to the primary care dashboard with that additional interactive where people can really dig into the data and additional cuts on their own. So moving right along to primary care. So the update here is that we published it, which is great. So the second iteration of the primary care dashboard was published last month. A couple things to highlight. So we've mentioned previously, we have a new interactive component. So we focused on the finance and the equity domains. And so whereas the PDF has statewide levels in the interactive Tableau, you can dig into payer-specific spending, and on the equity side, additional stratifications such as geography, family income, and other socio-demographic dimensions beyond what is included in the PDF itself. And we did include some new and updated measures, which are listed here. So on the next slide, so a couple key findings from the dashboard, just to go through these really quickly. So overall primary care spending represented 6.4% of overall medical spending across all insurance categories. And putting some of these into context, Milbank released a national scorecard on primary care a couple months ago. And so this 6.4%, or Massachusetts, is roughly right around the national average in terms of spending. There's a variety of definitions as to how to measure primary care spending. But in terms of Milbank, which looked across states, Massachusetts is right around the national average. And then, so based on our primary care spend data that we collect by insurance type, Mass Health, MCO, and ACOAs, so the commercially managed Medicaid plans, accounted for 7.5% primary care spending, and also had the highest use of alternative payment methods in 2022. Medicare Advantage had the lowest primary care spend at 4.2% in the same calendar year. And then two other findings to note quickly. So in the capacity domain, we note that the percentage of physicians that are leaving primary care, we have 2019 and 2021 included in the dashboard. That has increased from 2019 to 2021. And in addition, we are now higher than the national average, whereas that was not the case when we published the first iteration last year. And then one quick finding from the equity domain, which relies on the MHIS, or the Massachusetts Health Insurance Survey data. And so for calendar year 23, it's shown that Hispanic residents reported lower rates of having preventive care visits and also higher rates of having avoidable ED visits. So I'll pause here if there are any questions or additional feedback on either of these policy topics.
I have a couple clarifying questions.
Yes.
When you say 5.6% of physicians left primary care, is that the PCPs who left practice or left the state, or did some of them stop doing primary care but transition to specialty care?
It could be any one of those.
Okay.
So it's based off of, MHQP contributes that measure, and so it's based off of the master list. And so if you moved out of state, if you retired, all of those would fall under no longer leaving primary care.
Okay. And then my other question was just, I wondered if you could comment at all about this difference between Medicare Advantage and Mass Health, the 4.2% versus 7.5%, and how much of that is sort of a volume question, and how much of that is about parity between, you know, what you pay PCPs and what you pay specialists, and how that affects the distribution of spending. This is a curiosity more than like a pressing question.
It's a really good question. I'm trying to think if I can answer it and how best to answer it. So I think that the difference in spending, so this is the commercially managed populations for both of those programs. And I think it's something that we have obviously noted and are still digging into. Honestly, we have only collected the primary care behavioral health spending data. I think this is our like third or fourth year collecting it. And so that trend is consistent over the past couple of years of Medicare Advantage has been lower. In terms of the specific drivers behind it, every year as part of this process, we ask questions about payers that are submitting this data. And so I would say, honestly, it's still something that we are trying to untangle and gain insight into, which isn't a great answer, but it's the best answer I have for you.
That's great.
This might be stating the obvious, but I just want to make sure that we're talking about proportion out of the proportion of spend.
Right, right.
So it's not, sort of like total healthcare dollars. It's the proportion of each of those respective measures. Okay.
Right.
That's what
Yeah.
is.
And my last thing is more of a comment. If you guys want to look into it more, there is some recent evidence on how losing a PCP can adversely affect health and results in sort of use of the ED for avoidable reasons and things like that. And so as you see an increase in primary care exits, it might be worth considering whether you can look at adverse consequences associated with those exits for patients who had established relationships with those PCPs. And I'm happy to look into the relevant research.
That would be great. Thank you.
Do we or others know how many full-time equivalent primary caregivers, docs, NPs, others, are working in the Commonwealth? And do we know how many are needed?
We do include how many are working in the Commonwealth. And so it's based on providers that are spending at least, I believe, 20 hours on direct patient care. So we have it as a rate. So in 2019 to 2020, there were 115.3 primary care physicians per 100 Massachusetts residents. It's a slight uptick from 2018. 100,000, thank you. It's 3 o'clock, numbers are kind of hard. So
It's highest in the country.
I know. So we do have the number in terms of what the correct number is or what the target is. I think that is still open for discussion. We also show that a good amount, we ask people, do you have a primary care provider? Do you have a usual source of care? Have you had difficulty seeing your provider? And so I think the percentages of residents that are answering those questions, saying, no, I can't get in to see my PCP in a timely manner, or I don't have a primary care provider because of X, Y, and Z, would help inform and put in context this number of, is it too high? Is it too low? Is it just right? If residents are able to get the care that they need.
Well, if the governor gave a 15-minute state of primary care, what are the problems and what we're doing about it speech to the legislature every year, it might be good to have a sense of, do we have the right number, too many, too few? If too few, what are we doing about it? That's all I'm saying.
I think no one would say that we had enough primary cares, that we had too, or
Right.
no one can say we have too many primary care docs here. And I will just make a plug, that in our next 2025 workforce survey, we are going to be doing a targeted fielding for primary care so that we can better answer and better quantify some of these numbers around vacancy rates, turnover rates, and things like that.
I do have a related question, because the 5.6 talks about those that actually left primary care. But I'm
Yes.
assuming that you're also capturing if there is new primary care providers that are coming into Massachusetts, or that are just, starting new, so that you're capturing like the net gain or departure.
Yeah, so we have a measure that looks at incoming, so medical school graduates that are working in primary care 6 to 8 years after they graduate, as the best proxy we can of the incoming pipeline. And so that's about 20%. So we are trying to capture the inflow in addition to the outflow. We also have a measure looking at the average age of physicians as well.
Do you have percentage of primary care residencies that are filled?
We do not currently.
Should be one of the easier numbers to get.
We will add that to the list for future years to look at. Thank you.
And then I had a follow-up question from the last bullet. I think it's trying to show that there's a correlation between the lack of preventive care visits versus then needing to go to the emergency department for what would have been otherwise avoidable visits. Does that also correlate to primary care visits that are not necessarily for preventive care visits, but just regular primary care visits that are included in that category, or is it just preventive care visits? In other words, it looks to me like it's just visits to primary care for like the annual physical and things like that, but is it also capturing people that are not going to their primary care provider because they can't for regular doctor visits because they're sick, that are then leading to portable emergency department visits?
Yeah, so those measures come from our survey data, and so they are specific, they have a specific wording, so I would want to double check on that again.
Okay.
Anything else?
Faye, I can't, I couldn't tell if you were trying to interject.
No, I was trying to make sure that there wasn't silence on my side. And I was risking some words of wisdom.
Thank you.
Good, thanks, Erin. And just do an audio check. They can, and Jean and others, can you hear everyone in the room?
Yes, it's good.
Yes, very good. Thank you.
Good afternoon. I'm going to give you a brief update on the Massachusetts Healthcare Workforce Survey and Health Equity. Pleased to report that our very first annual Massachusetts Healthcare Workforce Survey 2023 results are available on our website. That's both the sector-specific results that we fielded across 10 healthcare sectors and our sector, sort of cross-sector statewide analysis are all available in a Tableau dashboard. The metrics that we have available right now are sort of diverse in the fact that they focus on key quantitative areas, such as like counts of full-time and part-time staff, employee race and ethnicity, and other sort of key sector-specific occupations around vacancy and turnover rates that we calculate here at CHIA. There's also sector-specific information on organizational perspectives, on challenges to recruitment and retention strategies for various roles, and how workforce shortages have impacted the services being offered across the sectors. Our cross-sector analysis essentially aggregates a lot of the common occupational categories that you see across these 10 healthcare sectors that we surveyed, specifically among physicians, registered nurses, direct care workers, and social workers, and sort of provides some deeper insights onto vacancy and turnover rates and how they compare by sector. Here for you are just some highlights from that cross-sector analysis that we performed. Specifically, our analysis shows key differences in race and ethnicity across sectors and how the distribution of employees who identify as a member of a racial or ethnic minority compare based on role and by sector. Here you can see that most employees in leadership positions identified as white and Hispanic across all of the sectors, majority of the sectors. In community health centers, that number was about 37%, and in emergency medical services, EMS, that number was more like 93%. We also sort of aggregated data across sectors to allow users of our dashboard to view statewide rates for vacancy and turnover by occupation, which here is the highest in social workers, and to see how rates compare by sector to better understand where gaps in capacity occur. For example, of the sectors who employ registered nurses, home health and nursing homes experience the highest vacancy and turnover rates. Our cross-sector analysis also includes information on how organizations are mitigating certain workforce shortages and how they're attempting to boost recruitment and retention across some of the occupations that we surveyed about. And in general, most organizations across all the sectors that we surveyed are really increasing the wages of their employees to combat those issues.
So I think the plan for future fielding, you can switch to the next slide. We're really excited to start fielding human services specific survey later next month. And that survey is going to focus on similar metrics that we included in our 2023 survey so that you can compare the human service sector to other sectors that we surveyed last year. Also a future consideration for us for our next cycle in 2025 would be sort of vetting how to best get in touch with physician practices specific for primary care, like we just discussed. We are sort of thinking about the best strategies for contacting this sector. We struggled a little bit in 2023 to reach everyone, to get the right contact information, and to get a really robust response rate from that sector. So we're really looking to sort of vet alternative approaches to surveying the sector. Our team is also working with EOHHS and DPH to prepare an integrated workforce dashboard, which not only will take into that demand side detail that was the subject of our 2023 survey, but will also take into account some supply side data that might be available. So we can really better comment on pipeline issues that are affecting the healthcare workforce. And just in general, really a lot of planning is underway for the next fielding of the full survey across all sectors in early 2025. Any questions about workforce?
Have you gotten feedback on your report?
Yes, we did get some feedback. We heard from the Mass League that they found our metrics extremely useful. I think they were putting together some policy briefs to sort of comment on how CHCs have been affected by workforce shortages. And it was really great to hear that that data has already been useful as they start to sort of comb through it. And we hope that by making this data available, more trade associations, more healthcare sectors will be able to use this data to better understand workforce shortages and how to mitigate them.
Well, Haley, I will also add to that. I had the opportunity to speak at the annual meeting of the Association for Behavioral Healthcare a few days after the workforce survey was out, and I used a number of the data points specific to the behavioral health sector from the interactive dashboard on the CHIA website in my remarks, specific around some of the vacancy and turnover and the challenges to recruitment and retention, the organizational strategies. And I basically quoted 5 or 6 stats taken directly from the CHIA website in my remarks around some of the challenges that they're facing and in retaining workforce and how that has led to people, essentially being able to, taking on more work, leading to burnout, which is then one of the reasons that people are leaving these positions and how, that can lead to kind of a vicious cycle. And I just asked the audience of, 300 people, do these findings in this CHIA, survey, do these resonate with your experience that you're feeling in your day-to-day work? And it was like an overwhelming, yes, everyone raised their hands and said, yes, that encapsulates what we're feeling. So an overwhelming response of validation.
Well, we were able to capture the mood.
Yeah, I just wanted to echo that as well. And I was in David's audience when he was giving those remarks. David's has always been good, but those remarks were just outstanding. So thank you. And I was going to echo that. The reports are excellent. And then they are, to some extent, ironically, this is not new information because we feel that coming from the behavioral sector, we are pretty familiar with these statistics. But the power of making these statistics more broadly sort of appreciated, understood is really important. For example, nursing shortage in the 30s and 40s% is very, very concerning. So these are sophisticated clinicians that have critical roles caring for some of the most complex, vulnerable people. What does that mean to the overall quality of healthcare? So I think we need to pause and think about, is this okay? And if not, what do we need to urgently do about that? Which is obviously outside of the CHIA discussion, but broadly speaking, from a policy standpoint, there's quite a bit of urgency. Just the more awareness that we have collectively, the better. So thank you for the report.
The only thing I would add, just to Faye's original question of the feedback, which another sort of positive note, which validates and was really one of the part of the underlying goals of this initiative was to sort of quantify in an objective way. What we've heard from different associations that are now out there using this data is they had, for many of which had conducted their own member surveys, but they feel like using CHIA data in their various advocacy efforts has felt more powerful and has had sort of more benefit than just going and saying, okay, yes, we conducted a workforce vacancy turnover rate within our own membership, and having the objectivity and independence without an agenda attached to the numbers and figures. A lot of associations has felt like that in itself has been really valuable, and I think are looking forward to working with us and partnering to evolve and improve this survey in future years.
Thank you. It's important to see how our data is being used and appreciated. So it's good to hear. Thank you.
I'm also going to give a brief update on our health equity strategy. As a part of CHIA's 5-point equity strategy, one of the areas for focus for us is really enhancing existing data assets with equity relevant data so that we can better capture healthcare disparities. And so that's sort of item 2 here folded. CHIA right now is developing an initiative to collect demographic data, specifically SOGI-RELV data elements and member address from health insurance payers to enhance our existing APCD. As all of you know, the APCD is a really rich source of eligibility and claims data with data from more than 80 payers, and one of the holes that we would like to sort of augment is around the demographic data that's available to us. Right now, we have gender, zip code, and preferred language included in the APCD, but we would propose to augment this data in the APCD with data that payers may already be collecting so that we can leverage that available data and better monitor disparities in coverage, access, utilization, cost, and quality, affordability, as well as other topics that might be of interest to sister agencies, specifically by race, ethnicity, region, and other demographic factors. Right now, CHIA is wrapping up a sort of internal planning phase for this project by finalizing a list of specific data elements that we would be interested in collecting and ensuring that some of the data standards and taxonomy of those elements are aligned with some of our other data assets like the EHRD data set. So in terms of next steps, our plan is to start engaging with payers and state partners to better understand what data elements may be available and the best ways to sort of facilitate that collection from a technical perspective. And then later this calendar year, CHIA will begin to prepare for some of the infrastructure support that will be needed to intake this data, with ultimate plans of being able to collect that member demographic data in August of 2025. Happy to take any questions.
It sounds like this is collecting the data where the payers are already collecting demographic data. Do you have any sense, or do you have a plan to sort of learn what the missingness is going to look like on the basis of the payers just not in the habit of collecting it or doesn't collect it incorrectly? Because if there are patterns in that missingness, we have it for Medicaid patients, mass health patients, but we don't have it for our commercial patients. I think that's relevant to know in terms of supporting future data collection.
Definitely, and we do have a little bit of an idea of what some payers may already be collecting. The QMAT 2023 Health Equity Data Standards Implementation Survey was fielded. 9 payers responded to that to give us sort of an update on what elements they were collecting. And so we sort of have that as a data point to give us some initial thoughts and perspectives on what might be available. But I think a lot of this work to sort of figure out missingness, challenges to collecting this data will probably come when we engage with the plans to get a sense of what data is available that we could sort of augment. It's a great point.
Okay. Other questions for either Erin or Haley? A lot of work. Thank you for updating us. Great. Okay, now we turn to the executive director report.
The first couple of things, just to run through, are legislatively focused. The both branches, the House and the Senate, have put forward and enacted their own versions of their FY25 budget proposals. They are now moving into conference committee where they'll be reconciling differences and an attempt to get a budget FY25 GA budget in place by July 1st. I think top line, both branches include a modest increase for CHIA. So no real concerns going into the conference committee process. We feel like regardless of which number CHIA comes out with, we will have sufficient resources and funding to tackle our existing responsibilities and priority projects. Any question on budget before I move forward?
That's good.
In terms, sorry.
I was gonna say, that's good.
Alan, did you have a question? In terms of a legislative update, as mentioned earlier, there are several major pieces of legislation moving through right now pertaining to healthcare, and some have more direct impacts on CHIA than others. But to note, the House passed a fairly major health reform market oversight bill just last month. We expect the Senate to take up their version of that bill in the coming weeks, but a few areas to note in the House bill that add or expand CHIA's current responsibilities. So one, there's a new requirement for hospitals to disclose to CHIA the audited financial statements of their out-of-state operations of a hospital's parent organization and other significant entities with material interest. So we expect that to be an extension of our existing work, but we know that it's expanded in the sense that we have a larger authority and a broader reach to be able to look into the financials of the out-of-state parent organizations and other entities that we know have controlling interests or sort of operational oversight and management. Not so dissimilar to the conversation we're having with respect to nursing facilities. There are additionally provisions there expanding CHIA's referral authority to the HPC, allowing CHIA to identify and refer healthcare entities that meet an expanded criteria to the HPC as part of the performance improvement plan. So right now we have a sort of a set of criteria with a somewhat rigid threshold or parameters for those entities that we can refer over to the HPC, which is right now really looking at health status adjusted TME. The provision in the House bill would allow us to look at not just health status adjusted, but other spending trends and criteria. And then finally, another sort of major provision that we also mentioned here already is moving the Health Planning Council under the Health Policy Commission. CHIA has a seat on the council, and we expect not only through council's work, but through the sort of normal day-to-day provisioning of data and analytics to HPC, would imagine that the Health Planning Council and the work that is directed from there will entail sort of that, not an insignificant amount of resources from CHIA. So all to say that we're still waiting to see what comes out as a final product. We'll have a little bit more information once the Senate takes up their bill, but hope to have sort of more definitive updates for this group at our September meeting. I would also just note that there are a number of other bills that are pending in the legislature that we expect them to take up between now and July 31st that have impacts on CHIA. There are pharmaceutical transparency bills, and there are a number of other long-term care bills, again, as mentioned, that would have new directives for CHIA in the financial analysis, as well as new sort of data collection streams and the like. So more to come. Remains to be seen how much the legislature will tackle between now and July 31st, but I hope to have more concrete and definitive updates at our next meeting in September.
For those
So
of
with
us
that,
not steeped in the legislature, could you just quickly remind us of the timing and the process and where we are in this cycle with the legislation that you're referring to?
sure. So the legislature follows a 2-year session. The session technically ends on July 31st, meaning July 31st is the last day that if the legislature were to take up and pass major legislation necessitating a debate, they will need to do so between now and July 31st. So we expect of the bills that just were discussed, we would expect though any major healthcare bill to necessitate debate, and is something that the legislature would take up in a formal session. So we would expect to see action, if any at all, on these bills between now and that July 31st deadline.
So this is still the beginning, and really, this is the House bill that we were reading about in the papers?
Yes, so the House took up their version of a healthcare market oversight bill. They enacted that. The Senate has yet to bring their proposal to the floor for debate, but we expect them to do so in the next couple of weeks. From there, they would go into conference committee, assuming that there are some differences between the two bills that they would need to reconcile. And the conference report is the sort of final product of that conference process. And that is the conference report is what we would expect the legislature to take up before July 31st.
Great, thank you. Any other questions on legislation? Questions on where we are in legislation? Okay, thank you.
The next item is a request item that I'll turn it over to Alan to raise, but it's really pertaining to CHIA's sort of evaluation of essential services and providers. I'll turn it over to you.
Thank you. Very briefly. So when we look at the name for CHIA, we know it's not the Division of Healthcare Finance and Policy, and we know it's not the Rate Setting Commission, earlier incarnations. But we do see information and analysis. The information's great. The analysis is usually terrific. But I think the only shortfall I can see is that it might be broadened. If you and we wanted it to. So wanted it to be broadened. So I think back to when President Kennedy was elected, we had 141 hospitals in the state, and we have 60 now, give or take. depending on how you count. Stewart has 7 or 8 or 9 hospitals, depending on how you count. And about 10% of the ER visits. So I'm concerned that we see lawmakers pushing for retirement, healthcare protection for 30,000 Stewart employees. We have legislation being considered in the general court about preventing the next Stewart from happening. But at the same time, the current Stewart is happening. And I wonder whether more information, if it could be provided quickly, could help inform public discussion. So we see things like, as Stewart flounders, I guess they mean founders, behavioral worries over the fate of its only hospital. And that's looks kind of a concern. Payer mix issues, a lot of Medicaid patients, a lot of Medicare patients. Is given the wonderful data that Stewart doesn't have or doesn't want, but that CHIA does have, I wonder whether CHIA can say anything useful to inform the ongoing discussions. For example, if a certain hospital were to close now or by its next owner or the owner after that, is there enough inpatient capacity nearby at the 2 or 3 other hospitals serving those cities, towns, or zip codes to handle that? Or would there be a need to add beds at great cost at surviving hospitals? And similarly for ER waiting times. At peaks, weekends, winter, would there be the absorptive capacity? What would be the effect on access and quality of care at surviving institutions? If St. E's were to close, if Morton were to close, Holy Family or Haverhill would say. And with available data, can anything be said about how optional or unnecessary these hospitals are, or how essential they are?
So I will open that up to the council in a minute, because I think that's really sort of in the purview of the council to discuss. I just wanted to, as a table setting item, just sort of in response to the first question around what useful information does CHIA have on this? To give context to the analysis that we circulated with the group on Friday, that was shared with our sister agencies as they're working in planning preparedness for the current Stewart situation. And that analysis gets at many of the metrics and indicators that you just mentioned, looking at the utilization, top diagnoses, the communities that patients from the various, not only Stewart hospitals are coming from, but also a scan of the surrounding hospitals in the region, sort of mapped again, each of those Stewart hospitals to conduct the very analysis that you're mentioning here. But I want to open it up to the group to your broader question.
Yeah, so I think I want to be careful about the scope of CHIA versus the scope of DPH as the regulator. And Karen, I hope you can help a little bit here when just talking about some of the great work that DPH has been doing in this space, because I do feel like using the information that was provided by CHIA, DPH has been able to do a deep dive analysis, but I don't know what the role of this group would be to provide that analysis. I think this is more, we can provide the data from here and to the regulators, and they are doing their jobs through the command center that was established a few weeks ago, and their ongoing monitoring of the hospitals and the hospital systems. They've also been connecting regional roundtables. And so I think that the data feeds into that analysis, but I don't know that it's necessarily within the scope here to do that.
I guess the question I have about it is whether, for example, they have done or are doing or are able to do an analysis of if, say, Holy Family closes, where would the patients probably go? Assuming that all of them went someplace. And would those other institutions have the open beds?
Yes, I can attest, Dr. Sager, that there are standing convenings that include representatives from all market participants to address the very questions on a real-time basis, including pulling in the Massachusetts Health and Hospital Association as a direct embedded partner with the data network. And I would be more than happy to take some of your follow-up questions if you would like further detail, again, within the realm of both CHIA scope and appropriate considerations of policy that is currently under development. So I'd be happy to do that.
Thank you. What would be examples of appropriate considerations?
I would defer to others around the room who have been engaged in government, including yourself, Dr. Sager, but there are certain policy and development considerations in terms of levels of how immediately public a current policy and development topic is. And so I'd be happy to maybe connect you with our general counsel's office, who give you more specifics on those parameters, which ultimately derive from statute. And then there are follow-up regulations that describe that in more detail.
So,
emails.
Yeah.
Or I'm happy to provide my contact information and we can follow up.
actually, as chair, if I could intervene for 1 second, and, you know, and an independent chair. But having been around back 15 years ago, I think what we're doing right now to some degree sounds like the perfect role for CHIA. You know, when we were created, it was at a time when people said, we need information that everybody will agree on. And then we can disagree on policy, we could disagree and have arguments about it, but at least we're all going to have the same facts. And it looks like what you are providing now are the right facts so that the Health Policy Commission and others who are charged with coming up with the policy can ask us, for example, what they need, and it'll be the facts. So the material provided was actually very helpful, Lauren, in thinking about that, because we really don't want to be engaged in deciding things that should be decided by others. What we are engaged in is providing the information so that people can make the right decisions. I think we're on the right track here in terms of the role of CHIA, Alan. Go ahead, Alan.
I couldn't agree more. And the question is, which facts? And this pertains, there's a parallel here to the earlier conversation about financial models that have been found to be accurate in predicting which hospitals go bankrupt a year ahead or 5 years ahead. So the question, and as opposed to putting a lot of numbers out there and leaving it to others to try to figure things out. And in this case, perhaps, especially the public, and maybe especially the public in the cities and towns who might be affected by a closing. So could we say something like, if this Stewart Hospital were to close for whatever reason, at whatever time, 6 months or a year from now, or sooner, how would the nearby hospitals be affected? Would there be enough empty beds, not just in July, but in December, to care for those patients? If that information already exists, shouldn't it be made public? If other agencies have analyzed those key data and compile them. I haven't seen it. I've asked for it. Maybe I haven't asked the right people.
I think that's where the idea behind the command center came from with DPH, is to ask those questions and to do that analysis. I think to Karen's point, because of the active bankruptcy case and we're going through the court process, I think that limits the amount of information that is available. But I think Karen can probably point you in the right direction to ask the right people, because they understand better than I do in terms of where the firewalls are in the policy and development.
And I do understand that the meeting today is to talk about your interest I've been listening intently, Dr. Sager, is to think about CHIA's role in information that it provides and what happens from there. I think I heard a slightly different question just now, which is in terms of some of that policy making and those real-time decisions that in deference to many of the stakeholder participants, I thought I heard a slightly different question, which is, where is the public space where some of that real-time debate gets plugged in? And I don't know if this council is sort of the right group to address that, but I am very happy to take that question to back to my secretariat, for example, and have a follow-up with you on that question.
Thank you. I don't think the bankruptcy court or any legal process could conceivably, as I imagine it, I may be wrong, influence the availability or provision of objective facts. This is not like people say, I don't think this is like people saying, we don't comment on existing litigation. I don't think that's the case here, but others are more professionally prepared to address that. I think the question is whether what I think of as a few key numbers on absorptive capacity exist already, and if not, why we shouldn't make it available.
Just to follow on to that, what are the key numbers that you're thinking? Because again, the utilization, the analysis that we had circulated, that's just sort of one example, certainly not an exhaustive list of the related analysis that we've done. All of those figures are publicly available on the CHIA webpage. I don't know, I think it would be sort of a futile effort if we were to sort of like come up with a data book or dashboard for every single scenario related to Stewart. But I think my point is a lot of those utilization numbers and that lend themselves to capacity planning are available on CHIA's website. So it would be helpful to understand from you when you say key numbers, what those are, and perhaps we can go back and identify are those things that we already have posted on our website. Maybe there's a way that we can display them in a clearer manner, but would be interested to hear what those sort of key metrics are.
So for the easiest to measure would be inpatient absorptive capacity. So if, let's say, St. Eve's closes, or more simply, Holy Family were to close, where do the other patients who live in the zip codes or cities and towns where Holy Family patients come from, where are they now going? Since they're not going to Holy Family, where do those admissions go? And then can we distribute the Holy Family admissions back to those other hospitals in the same proportion in relation to the other hospitals used by the residents of the cities and towns who do use Holy. That would give us, I think, a much more accurate sense of whether whether the existing inpatient capacity would be sufficient to handle the closing of the hospital. And I think it would be very hard for other people to do that.
If I can back up even more, like the way I imagine this is sort of you take the APCD, I don't know which sort of patient level qualification rate that you have the APCD, because public, like we don't, as researchers don't get like address, but if you looked at of the patients who were seen in hospital X over the past 12 months, if hospital X closed, how many of them would lose their geographically nearest in-network hospital? And if hospital X closed, what's the next geographically nearest in-network hospital? That's sort of the ex ante before you get to the passive question. That's how I think you assign them to the hospitals.
This could be done geographically, but I think, and that would be one way to present the information that would be useful. A more granular way of presenting it would be if this percentage of the people in Methuen use Holy Family. What about the people of Methuen who are admitted to other hospitals? Where do they go? In Lowell or elsewhere? Or even unimaginably in New Hampshire? Can we distribute the Holy Family admissions back to those other hospitals in the same proportion that Methuen residents who don't use Holy Family now use those other hospitals? And with the patient origin data, I think that's a reasonable exercise. And I don't know how time consuming it would be.
So I'm going to actually intervene here. I think it's a great conversation. And I think I've raised two questions. One is a broader, more philosophical of what is the role of CHIA in a number of different ways. And the second is a more granular, what are we doing now with Stewart? And rather than having a conversation in our last 5 minutes, I guess I would ask that the committee that Karen referred to, I'm making an assumption, is asking a lot of these types of questions. I think Lauren was trying to answer some of the information that was provided, but it's appropriate for that group then to get really thinking about it. Because as you know, it's the question you ask that matters too, and then the how. So we're not going to solve the what and the how here. So I would ask that we get back to you and we then have a broader conversation in our future board meeting.
And just a friendly amendment for me, Faye. What I would, and looking forward to following up with Dr. Sager on is I'm hearing pieces of interest that are more than what's factually available, information, what's both publicly available or otherwise, and what any of us can do in pulling the great information that exists and making an assessment. And by definition, I can't say that, Dr. Sager looking over the public data, Sandy Belitsky, David Sells, anyone around the room would come to the exact same conclusions from that data. I see and I'm hearing a genuine interest in some of those policy assessments, and I'm very sincere in following up with you on your interest in what's happening, again, within the bounds of what is, possible. I think that's different from the distinct question of, what's CHIA's role? And I would definitely defer to this group if they wish to form,
No, actually, I was going to say, I think he's raising the question. I also think we need to think through the enabling legislation, which was very prescriptive, to be honest. So it would be within a context of what we are now.
Yes, and I think that, yes, is something that we would defer to you as chair on, you and Lauren on next steps on that piece.
Well, it's funny you mentioned the enabling legislation. So section 3 says something like—
You're never going to get to the ABCD. Keep going.
Collect, analyze, and disseminate. Collect, analyze, and disseminate information regarding providers, provider organizations, and payers to increase the transparency and improve the functioning of the healthcare system.
Yeah.
What more could we ask for? That language looks very clear and adequate to me.
Exactly. Then read the role of the council. So we have to fit it all together, and it's a broader conversation, I'm afraid, than we can have in the next 5 minutes, but it is a really good thing to bring up and a great discussion.
Well, I would be very uncomfortable waiting until September. But because 3 or 4 hospitals might close by then, and maybe accurate information on the consequences of those closings. We don't want to say, if only we had known then what we know now. if it's possible to know now what we need to know now.
And my sense is that a lot of the analysis that you were looking for is actually, has been done and has been not just by CHIA, but others agencies. So I do feel like this is something that we can either follow up on, if there are specific analyses that you feel like CHIA should be reporting on, that again, that are sort of within our scope, but the utilization of the capacity mapping that both you and Adriana had mentioned are numbers that can be pulled from our utilization data, which has been shared with the relevant state agencies that are working sort of actively on this on a sort of 24/7 around the clock manner. So I guess my assumption would not be that this analysis has not been done or the very sort of analysis that you had laid out. I think a lot of that actually has been done by other state agencies.
On the specific question of the absorptive capacity of the other hospitals, because I haven't seen any of them. And I assume it's public information.
I can't speak to whether, how much of this DPH is putting out in the public, but I think some of that analysis has been done.
Are you asking me to make a Freedom of Information Act request? Forgive me, I just don't understand.
I think, Dr. Zager, to go back to the question at hand, which is what is the role of CHIA?
Yeah.
And I think CHIA is doing its role, is providing the data and information to the regulatory and oversight agencies to do their role. And I don't think it's their role to do this type of diversion analysis. As was just highlighted a minute ago in the conversation between you and Adriana, there's a lot of decisions that go into making that analysis. There are different assumptions about how you conduct it, what exclusions you make, what type of, that go into that and then make a difference in what type of outcome comes out of that. And I don't think that's the role of CHIA. I think that's the role of the regulatory and oversight agencies and the policy agencies that have a clear policy role.
Well, I think of it as analysis. I don't think there are assumptions that would greatly affect the outcomes of the analysis when I've seen this done in the past. Are you saying that that the analysis of where the patients would go if this hospital were to close have been done?
I'm saying for the conversation today, I don't think CHIA should do that. And I don't think it's their role to do that. And I don't think it's helpful for them to play that role.
Okay, but I was asking a related question. Have others done those analyses?
I don't have to answer that question.
Well, we're not in court. I was just curious. Because you were suggesting that they had been done.
I think it's naive of you to think that no other agency has done that type of analysis.
That's why I was asking. I don't think I'm a naive person. I don't think you're a naive person. So, and I don't think name calling is something we would get involved with. Is it?
Well, you suggested earlier that only CHIA can do this type of analysis.
No, I didn't say that. I said CHIA might be best equipped to do it. I didn't say only CHIA could do it.
Well, I'm suggesting that that is not the role for CHIA. And I think we can conclude this conversation, because I do think it is the sense of this council that it is not the role for CHIA to be playing a large role on a policy question.
Yeah, I think of it as an analytic question, not a policy question. So I think it does fall within our purview, but I'm only one person. I do feel that we have a looming potential, as you know, but probably better than I do, potential public health emergency here. And it would be nice to have, I think it would be nice to have better information out there, especially for the public.
Alan,
I think that Karen's
Really
offer
sorry that
to
I-
connect you, Dr. Sager, with the emergency command center that's up and running. Seems like the best path forward for you to raise those
I'm
concerns.
sorry, I can't hear.
I think that, sorry, the suggestion that Karen raised earlier, I think what I heard is a sincere offer to connect you directly with the folks at the incident command center who are wrestling with these questions in real time, I think seems like the best path forward, I think, for your specific analytic questions, but also for the questions around public access to that data. I know she had to step out, but I think that following up with her is the right way to move forward.
Thanks very much for the chance to raise this issue. And we all hope
Right.
that bad events can be averted.
And CHIA is committed and sort of stands ready to support our colleagues across state government working on this. And, you know, through the data and analysis that we discussed earlier, and again, meeting requests as they come in for the next couple weeks, months. That's again, that is within the scope of CHIA. So we are fully committed to continuing to support that work within our role.
Thank you for bringing up the question. It is a good discussion. I can't tell you how frustrated I am that I'm not in person. Of all the times that I had to miss, I apologize. We only have a few minutes. I think we've sort of ended in a way that will continue the conversation moving forward, and definitely talk, Alan, to the command center that Karen offered. And I am going to hate to do this, but we have 5 minutes. And I promised that you would at least get to talk about the APTC to update us very quickly.
Well, thank you for being our most avid EAPCD cheerleader today. And just sort of a quick recap, the EAPCD has been sort of a longstanding project for CHIA that with the primary goal of enhancing our both analytic capacity of our all-payer claims data, but also making it more user-friendly, more accessible to end users, so that you didn't have to have sort of a PhD in SQL or whatever other acronym exists out there to be able to use and access and query the APCD. So that has been a sort of longstanding project over the last 5 or so years. We had contracted with IBM to not only stand up what we're calling EAPCD, but also maintain operations while we were in contract renegotiations with them this past year. It became clear that continuing to move forward with IBM, having them maintain once it was fully developed. And so what we were renewing or in contract negotiations to renew would be the ongoing maintenance and operations of the EAPCD with IBM. It became clear that from a CHIA flexibility program and budget standpoint, that moving forward with IBM was not the most sound approach. So we made the decision to end our contract with IBM at the end of March, and made the decision to bring the EAPCD back in-house. And so we are currently in the process of standing up the data copy and environment. We've had full sort of compliance and cooperation from IBM. They successfully transferred all of the data over to us. We are now working to stand up that data in our new environment and are targeting end of July to have that up and ready, so that end users, looking at you, HPC, and others, should be able to access data through 2023 data through September 30th. Will be available via SQL by the end of July. From there, we will work to build out the flexible analytics, and we'll continue to refresh with new quarters of data, and should plan to have a more detailed project timeline for this group in September. But I would say that we are currently on track. We'll have the most recent copy of data available by end of July. And from there, we will continue to update you as we're making decisions around flexible analytics, picking and implementing a new business intelligence tool, which we know are all sort of very important for, again, the end users and for the way that we think about accessing and the different types of cuts of data and analytics that will be made available with the APC. So wanted to just provide that more process update, but let you know that we are continue to be confident in our decision to bring this in-house. We're currently on track, on target, and we'll hope to have more concrete updates for you in September.
Thank you. I mean, we all remember the Affordable Care Act, which went, down because the technology didn't work. And if the technology here doesn't work, then all of the other conversations we've just had will be irrelevant because we won't be able to get the data. So thank you for a good report on that. And thank you to the council for a robust conversation. It was good. It's great to have kind of dialogue we had. Do I hear a motion to adjourn so we can, thank you. Anybody else? Meeting is adjourned on time. Thank you.
Thank you. Thank you. Bye-bye.
Bye-bye.
Thank you.